You're watching CTOM TV. Knowledge is power.
So Alex, you're going to tell us about bladder cancer today. So how would you like to do that?
It would actually be referred to as urothelial cancer,
Okay.
and it includes bladder, ureter, and urethra.
Okay, so urothelial cancer. Okay, go ahead.
Well, it's going to go over the risk factors,
Okay.
the genetic features of the disease, which can lead to targeted therapies, and then go over, some new treatments. And I really had to cut that short because I needed to shave. But there's lots, so
There's always some excuse.
There's a lot. So I just picked some of the newer ones that I felt are some good approaches.
Okay. I have some amazing notes in my hand that the
wow.
team prepared, folks.
Wow.
So assuming Alex approves these, because obviously you've got a lot to cover in a short period of time, we can get these posted to the Facebook page along with this video.
Sure.
So you've got some notes and don't have to write down everything he says super fast.
Okay. So the risk factors, smoking, obviously. It's always a risk factor for cancers. And it's related to about half of the bladder cancers in women and men.
Oh, really?
Yeah, that's quite a bit. Yeah.
What? Why is that? Are you going to get into that?
It's the different chemicals, the carcinogens released.
So. Why bladder? I mean, you think lung or throat.
Well, I mean, you're getting rid of all of these carcinogens through your urine and your excrement.
Right. So once they've been in the throat and the lungs, then that's
how they get shipped out.
I see. Okay.
So everything's going to pass through the bladder. Every poison you've ever had, literally.
Okay. What other risk factors, Alex?
So e-cigarettes. There's a recent study with mice, and it showed that 60% of the mice exposed to e-cigarettes had precancerous lesions, and also and then also I think it was about 10%, 5 to 10% that were exposed to secondhand e-smoke had these, these urothelial hyperplasia lesions.
Interesting.
Yeah.
I was there was something that I read recently about how the chemical makeup of e-cigarettes has been changed because they did identify.
Right. Yeah.
So even with those changes in it,
it's probably I'm assuming this is old data.
Okay.
Old data means like a year.
Last month.
Month. Yes.
Just be careful.
Yes. So that was probably with the old, and obviously, anything that is going to be in there, if it's a carcinogen, it's going to cause problems at some point in time.
Okay.
But I think nicotine in itself is considered a carcinogen at this point in time too. Okay. So the next thing is HPV, human papillomavirus.
Okay.
Interestingly, not surprisingly, the different strains have a different percentage. So HPV 18 is about 5.5%. 16 is about 13.2%. 11 is about 6.4%. And the highest is HPV 6. It's at almost 18%.
So there are quite a few of the different HPV strains can lead to bladder cancer.
Exactly.
Or involved in.
Yeah. And then one of the biggest factors that we've seen a lot of in the news and so on is your proximity to an oil refinery. Or a gas station for that matter, but an oil refinery in particular.
Really?
Yeah, and there seems to be this 10-mile kind of range. So a 10-mile circumference increases, if you're within that, it increases your relative risk by 1.19% average, as high as 1.31, which is quite a significant difference.
Yeah.
For risk. And interestingly enough, this risk is more in males than females. And so the relative risk for that in males versus females was 3.41. So that means there's a huge increase in men who live near refineries versus women.
Wow. And is there a presumption on why?
I would go with the presumption that the men traditionally work in these refineries. You know, it seems to be a male-dominated job. And so if they're living within 10 miles of a refinery, they probably work there. You know, I know we see a lot of these sort of cancers from people in Alberta working on oil rigs. So definitely, you know, and
an
within the
increase in
region,
certain
the
communities
tar
where there's
sands,
fracking and
a huge increase in
Yes.
fracking areas. You know, there was the Love Canal incidences. And then there's this whole area in southern Ontario where they have a lot of industry that has really high incidences of these sort of cancers.
Okay, so that something's in the air.
Definitely something in the air, yeah.
Yeah.
And you know, it's typically benzenes and those sort of chemicals that are byproducts of this.
So avoid working in the oil industry or living
or living near one.
Okay.
And then early menopause in women smokers.
Oh.
So women who went into menopause before the age of 45, who were also smokers, had a 45% chance of getting bladder cancer. And actually, it was a 53% risk compared to women who had bladder cancer or who smoked and
didn't have early menopause. Wow. So before 45 plus smoking, 53% increase in risk.
Yeah.
Wow.
If you have an early menopause.
Mm.
Yeah, so that's an interesting bit of data.
That is.
Yes.
It goes to show there's a lot going on, right? So there's a lot of variables that influence cancer.
Yeah, and I barely touched any of this.
I understand. We only have so much time.
Yeah, so the types of you know, bladder cancers or urothelial is basically a type called urothelial carcinoma of the transition cells. And in Europe and USA, that's probably about 90 to 95%, whereas squamous cell is about 5%. Interestingly enough, when you look at Middle Eastern countries, that number is reversed, and about 70 to 80% of the bladder cancers are squamous cell.
In what country, sorry?
Middle Eastern.
Middle Eastern.
Yeah, so it's a completely different type of cancer there.
Okay.
Yeah. So the genetics, very important because they can indicate what sort of targeted therapies are available for this. And as with any type of cancer, you want to get tumor DNA sequencing. That should be the first thing you do.
Okay.
So the genetics, FGFR3 is found in about 45% of bladder cancers. P53 mutations, 30%. RB mutations, that's a retinoblastoma gene, about 29%. PIK3CA, that's about 20%, and there's some targeted agents for that. CDKN2A, that's a checkpoint inhibitor, cell cycle checkpoint inhibitor, about 16%. And then there's a unique RAS version that we don't see in a lot of other cancers called HRAS, and that occurs in about 9%. We don't have a targeted therapy for HRAS as of yet.
Okay.
Then P10 mutations, which is a tumor suppressor, very important tumor suppressor, but it can also lead to treatments with AKT inhibitors and so on. And that's found at about 4%, and then AKT1 mutations at about 3%. So there's lots of targeted opportunities there for you know, potential targeted opportunities. So you definitely want to get tumor DNA sequencing. Very important. Obviously, since the FGFR3 mutations are at such a high percent.
You said 40 something?
Yeah, 45.
45.
Yeah. Since they're so high, obviously a lot of drug development has gone into FGFR inhibitors.
Sure. And there are things for P53 already?
No.
No.
Well, it's going to change soon, but there's nothing right now.
Okay.
It's a tumor suppressor. So I picked out about 2, 3, 4, 5, 6 of my favorite treatments for this. So there's a Checkmate 32, and anything with a Checkmate is an immunotherapy.
Okay.
And this one, this one was a follow-up of PD-1 inhibitor nivolumab compared to nivolumab plus ipilimumab, which is a CTLA-4 inhibitor. So, in most cancers we see that respond to immunotherapy, pretty well all of them have a better response to the combination of a PD-1 inhibitor and a CTLA-4 inhibitor. It just seems to be a synergistic combination. So in this particular trial, they looked at previously treated metastatic urothelial carcinomas, and the objective response rates were 26% for the nivolumab, the PD-1 inhibitor alone, and then the high dose nivolumab plus ipilimumab was 27%, and then the high dose ipilimumab, of all things, standard dose nivolumab, was actually 38%. So it seems like the CTLA-4 inhibitors are the winning driving drug for this subtype of cancer, rather than the PD-1 inhibitors. And then median duration of responses exceeded 22 months in all groups. So these are long-term durable responses in these patients. So definitely that's something to look at if you've already failed treatment.
Okay, that was the Checkmate 32 protocol. Okay.
Then there's gemcitabine and eribulin. Eribulin is a new type of, well, it's not that new, but it's a type of chemotherapy derived from a sponge. And gemcitabine is a chemotherapy agent that's been around for a while. And so in this particular case, they used them in platinum ineligible metastatic urothelial carcinomas. And they had a fairly good response rate of 50% in all patients. Yeah, so the overall survival in this was almost 12 months, a median overall survival. So, in patients that are really don't have a lot of options for, chemotherapy and haven't had any sequencing, this is a good combination.
I see. And that's an important distinction to make. These are for people who are quite far along, and these targeted therapies or other options that genetic sequencing could provide aren't available because they haven't had that testing. Still, we're getting 22 months or 12 months.
In this case, 11.9.
11 point.
Yeah, on average. But a 50% response rate is really good. And then there's a new drug called enfortumab vedotin. And this is a antibody drug conjugate that targets a drug or a pathway called Nectin-4. It is found to be active in these sort of cancers. These are patients that hadn't been treated with platinum or PD-1 inhibitors.
Enfortumab vedotin or verdotin. Enfortumab. And that works on the Nectin-4 pathway. And this is for people, this study is for people who already
failed
had
immunotherapy and pretreated. And cisplatin.
Okay, thank you. PD-1 or
cisplatin, which is one of the standard treatments.
Okay, that's good. Thank you. And that was a 44% response.
Yeah, so it's pretty good. So this is late stage patients.
Yeah, as you said, some had metastasis other places and
liver.
Yeah.
And so we're going to see a lot more of these antibody drug conjugates. I think they're really, it's what we call targeted chemotherapy or targeted therapy, because they have an antibody that takes it to the cell that's expressing that particular molecular feature.
It is important for those of you watching at home to understand that these new approaches, whether it's a targeted chemotherapy or certainly targeted therapies and immunotherapies, because they're so specific in where they're going and what they're doing, the side effects are
much less.
Yeah, so even if you're hearing chemo and your mind is immediately saying, no, I don't want to try that, understand that a targeted chemotherapy is very different from traditional chemotherapy. So definitely don't close your mind to that possibility.
Yes. And then for patients with FGFR mutations, there's this new FGFR. Now, there are a variety of FGFR inhibitors around. But this one is called erdafitinib, yes. And in a trial of an advanced urothelial carcinomas, the response rate was 40%, which is quite good. The duration of responses, which is equivalent to kind of a progression-free survival, was 5.6 months. So very new data, but definitely targeting FGFR mutations in this cancer is a definite approach to consider.
Definitely
And
beneficial.
if you have this, you want to very at least get yourself checked out for FGFR mutations.
Right. So you can, that's right. You can ask your doctor to test you for that mutation, or you can pay out of pocket for that. A single gene test, say about $1,000 Canadian,
Yes.
800 US or less
Mm-hmm.
for a single gene test.
Mm-hmm. And then there's just two more. So ramucirumab plus pembrolizumab, PD-1 inhibitor. And this was a basket trial where they looked at previously treated advanced gastroesophageal cancers, including and also non-small cell cancers, and also urothelial. It was kind of a basket study of a couple different types. So they found in the urothelial subgroup, they found objective responses in 13% of the urothelial carcinoma cohorts, and stable disease was observed in 38% of the patients. So their cancers didn't progress. So, relatively new study, a relatively new approach.
How new is relatively new?
I probably should have done a little more research on that.
We stumped him. Okay, all right, but it's new. But
2019.
okay. Oh, yes, that does sound relatively new for sure, since we're just a month or two into 2020 right now.
So there's one last one, lenvatinib plus pembrolizumab, and as you can see, there's a lot of immune therapy combinations with PD-1 inhibitors. I think from the original Checkmate trials, I think looking at that immuno combination of ipilimumab heavy treatments, it seems to be the way to go rather than the PD-1 inhibitors. But in this particular combination, it was fairly later line patients, and they got an overall response rate of 25%. It's fairly advanced patients.
Okay.
So, it's a good response rate. We'll see how that pans out.
And again, once you have some genetic testing and you know what's driving your cancer,
then you can really increase the potential for benefits of these cancers.
You won't waste your time on the wrong thing, for starters. Most important, especially when time is short. And yes, you can get a better targeted approach, for sure. Yeah. Well, that's kind of exciting. Then,
so to wrap it up, you really need to get tumor DNA sequencing if you have bladder cancer. Very, very important.
Because there's so many variants.
And yes, and these are just the variants, just some of the immune-based variants. So there's many different variants, so many different treatment approaches going on, combinations with PD-1 inhibitors and CTLA-4 inhibitors, just a lot of different approaches. So you could have a long list of different things to try, and you could have them tested, and you could be monitoring your specific type of mutation with liquid biopsies. There's a variety of different ways of approaching this. So definitely you don't need to stick with, traditional chemo for this.
Yeah. Even if you don't have a huge budget. Genetic testing does cost money. There's no way around that. But a lot of these protocols that you're talking about in different forms of treatment are much easier to access once you have the genetic testing to prove that that's the right treatment for you.
Yeah, you have to be able to prove it yourself.
Yeah, it's very common for doctors to tell patients there are no more options.
When they just haven't tested for them.
Well, maybe they can't, but because based on the data that they have available to them, there literally are no more options. But once you add tumor DNA sequencing or inherited mutations testing, and you start looking more deeply into what's going on inside your body, suddenly a lot more options open up. I've certainly seen it through
yes, for sure.
10 years, for sure. I don't know what our statistic is. It's at least 90%, wouldn't you say, where, with genetic testing, new targets are found?
Yeah, we always find something. Very rarely do we not find something. It's very rare.
So don't give up if you've been told there's nothing more, if you haven't had the genetic testing.
And even our inherited genetic testing, just with a small panel of 127 genes, I mean, we're finding what, 70% of
It's
patients,
that's almost 80%.
almost 80% of patients
Yeah.
actually have an inherited genetic mutation that's involved in their cancers. It's really high.
And now, if you looked online right now, you'd see that the current clinical statistic for inherited mutations being involved in cancers is between 5 and 10%. So what our data shows actually is that when people come to us and we have that inherited mutations testing, 80% of the time they do have inherited mutations which are targetable. So that
not 80% of the mutations are not targetable, but 80% of these mutations occur, and they will be targetable at some point in time. But what they do is give us a indication of what treatments are going to work and what treatments are not going to work. So they may not be targetable, but they will be clinically beneficial in the sense that it helps us guide therapies.
Right. Again,
so, we'll know that this drug is not an option for you. Don't waste your time with it. And since you have this mutation, then this drug may be a better, better treatment for you.
I see. Thanks for the clarification.
Yeah.
So it's not so much that there's a targeted treatment waiting for every inherited mutation we might find, but the mutations you have will either make certain treatments work better for you or not so good.
It'll help guide us, in picking the best treatment decisions.
Yeah.
And that's an important consideration that's ignored.
Right. And as you're saying that it's 1, 2, 3, 4, 5, 6, 7, 8. You listed 8.
That was just some of them.
That's just some.
It was
okay.
A huge panel,
so
yes.
Already it's understood that with urothelial cancers, there are certain mutations that are very commonly involved. So by all means, having testing to see how many of those are involved for you would be greatly beneficial to you and your doctor.
Yes.
Yeah. All right. Was there anything else you wanted people to know about this type of cancer?
No, I think that's about it. If you have any questions, please feel free to ask.
Yes, you can post them in the chat below. You can reach out our website, ctoam.com. There's a contact form there you can fill in and send Alex a question. And then we have a YouTube channel.
Yes, The Cancer Guy.
Alex likes that one. thecancerguy.com. There's hundreds of videos on there. Some are long, but there's a lot of 2 to 5 minute videos about pretty much any cancer and just about all these things we've been talking about genetic testing and liquid biopsies and chemotherapies and radiation treatments and all that kind of stuff. And diet, as we talked about a little bit earlier, and the importance of exercise. All of that stuff is there. I should say, I didn't say at the top of the hour today, but everything that Alex shares with patients, whether in the reports he prepares for them and their doctor to follow, or whether in any of these videos, there's a peer-reviewed medical journal reference to back up what is being said here.
We don't make up anything. It's all data.
These aren't opinions.
Yes.
So if there's something that you've heard and you'd like to go to your doctor and talk with them about that, but you want a little backup, that's what we're here for. So just reach out and let us know, and we'll prepare some information for you and consult with you and help you take these next steps to get these treatments. So next week, we'll be here Thursday, 1 o'clock Pacific Standard Time. If you can't make it then, as I know that might not be convenient depending on where you live and just your life in general, you're welcome to post any questions to our Facebook page before then, and they'll get answered then. But if you can make it, do join us and ask your questions live. And always these videos are posted for you to come back to and watch at your convenience as well. So we look forward to seeing you next Thursday. And in the meantime, you can reach out to us on Facebook, at the website, at ctoam.com, or go watch some more videos with Alex at thecancerguy.com on YouTube.
Thank you for watching CTOAM TV. Subscribe below and stay informed.